Hi everyone, our subject today is seizure and other paroxysmal disorder in pediatrics. Basics. Seizures arise from abnormal, excessive electrical neurological discharge in the cerebral cortex that lead to alteration of consciousness, behavior, motor activity, sensation, or autonomic function. Epilepsy is defined as two or more seizures without acute provocation. Seizures are classified in several manners. Seizure appearance, generalized, tonic, clonic seizure are the most common and severe. Partial complex seizure are focal. Absence seizure are unique form of seizure that do not pose a relevant physiological risk to the patient. History. A good clinical history is what going to help us decide the type of seizure and distinguish it from non-epileptic event. Best is to elicit history from the caretaker or parent who has witnessed the seizure. If not possible, history should be elicited again after the initial control of seizure activity. Questions that need to be addressed in all cases. What was the child doing when he had a seizure? What happened in intricate detail? Did the eye turn to one side? Did the child become stiff? Did the child have clonic movement or jerk or just brief flickerings of eye? How long the seizure did last? Was the child unconscious after the event and for how long? Did the child experience any weakness of any limb after seizure? Did the child pass urine and stool during the episode? Did the child suffer any injury during the seizure? History also should include a detailed antenatal history of mother, birth history, and developmental history to find out any associated risk factor or etiology of seizure. Age, family history of seizure, epilepsy, developmental status, health at seizure onset, febrile, ill, exposed to illness, complain of not feeling well, sleep deprivation, precipitating event or other than illness like trauma, toxin ingestion, previous head injury, current medication and change in anti-epileptic medication, other neurological sign, confusion, encephalopathy, weakness, sensory deficit, and change in vision, behavior, balance, or gait. Detailed history of symptom during seizure, aura, subjective sensation, behavior preceding and during seizure, loss of conscious, vocal, cry, gasp, speech, motor, head or eye turning or deviation, jerking, posturing, stiffening, automatism, important to determine if generalized or focal, respiration, cyanosis, change in breathing pattern, autonomic, pupillary dilatation, drooling, incontinence, pallor, vomiting. Symptoms after seizure, amnesia, confusion, sleepiness, lethargy, transient focal weakness, which is called Todd's paresis. Physical examination, vital sign, of course, ABC, need to be checked immediately and recurrently if the child continue to seize or unresponsive. Fever, tachycardia, bradycardia, or hypertension. Sign of head trauma and child abuse, retinal hemorrhage, evidence of intracranial hypertension, presence of fracture, bruising, head circumference, abnormal head growth, microcephaly, sign of systemic infection, meningism, CNS infection, responsiveness, skin examination, cafe au lait or ash leaf spot, facial hemangioma, suggesting neurocutaneous disorder. Neurological examination, pupillary asymmetry, altered mental status, fixed eye deviation, and focal motor weakness. Todd paralysis, as mentioned, suggest focal onset of seizure and possible underlying structural lesion. Seizure, if there is a question of continuing seizure, proceed with the recommendation for status epilepticus. Will be discussed in another lecture. Alert. Attention to adequate airway and breathing and need for oxygenation or ventilation support is the primary focus at presentation. Serum glucose level should be assessed as soon as possible. If the child continues to seize or has recurrent seizure, administration of an abortive benzodiazepine should be administered either rectally or IV. How to approach to child with seizure after performing history and physical examination. Is there fever present 38 Celsius or more? If it is yes, is there criteria for simple febrile seizure present? Age from 6 months to 60 months. Neurologically healthy child. Generalized non-focal seizure. Less than 15-minute duration. No febrile seizure in the previous 24 hours. If it is no, consider lumbar puncture and neuroimaging EEG. This is either complex febrile seizure or CNS infection, seizure with fever due to other causes. If it is yes, this is either sign of symptom suggestive of meningitis present like vomiting, headache, neck stiffness, Kernig sign, and Brudzinski. If it is yes, perform lumbar puncture. If it is abnormal, this is infection. If it is normal, this is simple febrile seizure. If patient has no sign of meningitis and have all the criteria of febrile seizure, this is of course simple febrile seizure. If the patient deficient or unknown immunization status or pre-treatment with antibiotic. If it is yes, perform LP. If according to the result, either simple or CNS infection. If it is no, this is simple febrile seizure. Now, if a patient does not have fever, is the history consistent with the breath-holding spell? If it is yes, this is breath-holding spell. If it is no, is it sleep-related? If it is yes, obtain EEG if suspicious of seizure. If the child age 2 months to 2 years, differential diagnosis, head banging, neonatal sleep myoclonus, myoclonic jerk, physiologic, hyperplexia, stiff baby syndrome or startle disease, epileptic seizure, electroclinical syndrome. As we mentioned, if it is sleep related, if the child age now more than 2 years and febrile of course, differential diagnosis, benign childhood epilepsy with the centrotemporal spike, narcolepsy, cataplexy, night terrors, myoclonic jerk, head banging, sleepwalking, confusional arousal. If it is not sleep related, any of the following feature present: recent trauma, focal component, post-ictal focal defect, no return to baseline, loss of consciousness after several hours, other condition increasing risk of abnormal neuroimaging result, and age less than 1 year. If it is yes, obtain CT if recent trauma, otherwise MRI, obtain EEG, consider drug screen, lumbar puncture, glucose, liate, calcium, magnesium, phosphorus. Seizure due to structural metabolic differential diagnosis, seizure due to structural metabolic causes, generalized seizure, and focal seizure. If it is no, patient has no recent trauma, no loss of consciousness, differential diagnosis, etiology suggesting by history and physical examination, consider EEG, liate, calcium, glucose, and drug screen. If the child age from 2 months to 2 years and febrile, differential diagnosis, generalized seizure, tonic-clonic, absence, myoclonic, clonic, tonic, atonic, unknown, epileptic spasm, seizure due to structural metabolic causes, paroxysmal torticollis, alternating hemiplegia of the childhood, jittery infant, benign paroxysmal vertigo, spasmus natus, stereotypical movement, other involuntary movement, caregiver fabricating illness, previously called Munchausen by proxy. If the child age more than 2 years and febrile, as these causes we mentioned here, also differential diagnosis may include syncope, breath-holding spell, cataplexy, torticollis, paroxysmal and spasmodic, hyperplexia, startle disease, myoclonus, hyperventilation, a drug reaction, dystonia, tic disorder, migraine variant, and psychogenic seizure. Alert! Hyponatremic seizure, serum sodium less than 120 milliequivalent per deciliter in infant with gastroenteritis, slow sodium correction is indicated. Apnea and hypoventilation from excessive administration of benzodiazepine, phenobarbital for seizure, monitor ventilation and oxygenation and avoid large doses. Prolonged febrile, simple febrile seizure with focal features can be associated with the herpes simplex virus encephalitis. Both conditions are indicated for lumbar puncture. Infant presenting with febrile seizure may have serious bacterial infection, bacteremia, meningitis, or sepsis without meningeal sign. Peers and pitfall, based on the history and physical examination, differentiate between seizure and other causes. Febrile seizures are typically benign, but determination if the child has serious bacterial infection, including meningitis, is critical. A febrile seizure may herald epilepsy, but no lab test or imaging is routinely necessary in the emergency department, only referral to neurology. Seizure without focal or other abnormal neurological finding is not consistent with or suggest of meningitis. Allow 5 to 10 minutes of seizure activity before giving a benzodiazepine while provide adequate support to maintain oxygenation. Seizures meeting the criteria for simple febrile seizure are generally benign event with the excellent long-term prognosis. 2 to 5% of general population will experience a usual simple febrile seizure. Of those, approximately 30% will have a recurrence. The risk of subsequent epilepsy following a simple febrile seizure is low and affected by various predictors such as age of occurrence, duration of fever, height of fever, family history, etc. Complex febrile seizures are defined as focal or prolonged, longer than 15 minutes, or occurring in a flurry of repetitive episodes during the febrile illness. Genetic factors are being increasingly recognized as contributing factor in complex febrile seizure. Remember, children younger than 6 months of age do not meet the criteria for simple febrile seizure and should not be evaluated along this pathway. The evaluation of complex febrile seizure should be individualized based on the presentation. A very prolonged seizure, a focal seizure, characteristic of herpes simplex virus encephalitis, or an abnormal neurological examination should prompt through evaluation for CNS infection. The diagnostic test for choice of herpes simplex virus encephalitis is PCR for herpes simplex virus performed on spinal fluid specimen. Tests should also be obtained for bacterial and viral etiology of meningitis. MRI should be obtained for all children with focal seizure. An EEG should be obtained acutely if concerned about febrile status epilepticus. By definition, the term complex febrile seizure applies to children between 6 months to 60 months of age. Outside that age group, seizure with fever can be due to multiple other causes like HHV6 virus, Shigella, immunization. A lumbar puncture is not routinely recommended for a child age 6 months to 12 months who will appearing and fully immunized who has experienced a simple febrile seizure because their risk of having bacterial meningitis is extremely low. Less straightforward is the recommendation for performing an LP on a child who has had antibiotic by any route in the day preceding the seizure or those immunization status is unknown or deficient, particularly for Hib and pneumococcus, which are known pathogen for bacterial meningitis. Most of studies regarding outcome of febrile seizure have been done on children with a high immunization rate because the outcome of febrile seizure for children with the incomplete or unknown immunization status or any pre-treatment with antibiotic is unknown, an LP is recommended as an option for these children. Any labs obtained, particularly complete blood count, should be directed toward evaluation the source of fever, not to evaluate the seizure. When considering bacteremia as the source of fever, the incidence of bacteremia is the same in febrile children under 24 months of age, regardless of whether they have a febrile seizure or not. Evaluation of infant younger than 2 months of age with seizure require consideration of causes mostly unique to neonatal age group. Causes may include hypoxic ischemic encephalopathy, intracranial hemorrhage, cerebral anomaly, infection, septicemia, meningitis, encephalitis, congenital infection, metabolic, hypoglycemia, hyponatremia, hypernatremia, hypocalcemia, inhibitor of metabolism, drug, neonatal abstain syndrome, kernicterus, other like pyridoxine dependency, genetic, epilepsy syndrome. This will be discussed in another lecture. Breath-holding spell should be distinguished from seizure before proceeding with an evaluation for seizure. The term breath-holding spell is somewhat of misnomer as the episodes are not due to intentional breath-holding. Cyanotic or blue breath-holding spell are described as prolonged expiratory apnea or sudden lack of inspiratory effort, often during crying. In pallid breath-holding spell, a reflex vagal bradycardia is responsible for the event, usually following a minor injury. Both can be triggered by injury, anger, or frustration. Apnea, brief loss of consciousness, tonic posturing, and occasional anoxic seizure can follow. Breath-holding spell typically occur between age 6 and 18 months, although they may be seen in children up to 6 years. Children recover quickly from these events and no diagnostic evaluation is indicated. However, affected children should be assessed for iron deficiency, which should be treated if present. The presence of autonomic symptom, altered level of consciousness, lack of suppression with the gentle restraint, and history of CNS insult or injury should raise suspicion of seizure. Non-epileptic event is suggested by a perpetual resolution with return to full level of consciousness or when the movement ceases abruptly when children can be aroused from sleep. Other children experiencing seizure may additionally manifest abnormal vocalization, incontinence, or a change in mood or behavior preceding the event. They may subsequently be able to describe an aura or other pre-ictal symptom. Head banging Jactotia capitis nocturna is a common behavior of rhythmic and fro movement of the head and body. Children have no memory of this behavior, which typically occur as they are going to sleep. It typically resolves by 5 years of age. Myoclonus refer to brief involuntary muscle jerk. Its clinical significance vary significantly based on whether it is occurring as an isolated involuntary movement or as a component of more complex epilepsy syndrome or movement disorder. It is common and usually benign in sleeping infants, neonatal sleep myoclonus. Random myoclonic jerk can be normal physiologic in people of all age during sleep. In infant, the condition can be distinguished from seizure based on its occurring only during sleep and ceasing when the infant wakes up, as well as the absence of any autonomic symptoms. It resolved by 2 to 3 months of age. Infant with hyperplexia, stiff baby syndrome, or startle disease may have nocturnal myoclonus, stiffening upon awaking, and exaggerated startle reflex, and occasionally apnea. A few children may continue to experience an exaggerated startle response with stiffening and falling throughout the life. The term epilepsy defines a disorder in which there is persistent underlying abnormality of the brain which can generate seizure activity. The term applied after the occurrence of 2 or more unprovoked seizure and is classified based on the number of features, including age at onset, cognitive and developmental antecedent and consequence, neurological examination, EEG characteristic, triggering factor, and sleep pattern. Epilepsy as diagnosis should be distinguished from electroclinical epilepsy syndrome. Electroclinical epilepsy syndrome are clinical entities of a specific complex of signs and symptoms compromising a distinct clinical disorder. This term was proposed by the International League Against Epilepsy, ILAE, in their 2010 report on terminology to reduce the emerging use of the term syndrome in previous classification system. Not all epilepsy meet criteria for electroclinical syndrome. Etiology of epilepsy can be genetic, structure, metabolic, or unknown. Epilepsy syndrome may be attributed to an identifiable problem, cerebral or metabolic abnormality. If not, they are labeled as idiopathic. The term cryptogenic is no longer used and presumed to have a genetic basis. Neuroimaging should be performed emergently if there is a risk of serious condition requiring immediate treatment, like intracranial hemorrhage, brain swelling, space-occupying lesion, head trauma occurring in close proximity to the seizure, associated with any loss of consciousness or change in mental status. Persistent headache or vomiting would meet this criteria. Imaging should also be considered for children who experience a focal seizure and children with the known condition that predispose them to abnormal neurological neuroimaging studies, like developmental delay of unclear etiology, sickle cell disease, bleeding disorder, hydrocephalus, cerebral vascular disease, malignancy, HIV infection, hemihypertrophy, or travel to an area endemic for cysticercosis. Neuroimaging should be considered when a child is found unconscious and it is not clear whether trauma or seizure caused the loss of consciousness. MRI is a preferred imaging study in the evaluation of seizure because of its increasing sensitivity relative to CT. A CT, however, can be adequate to detect emergent treatable condition. It is the preferred mode of imaging when acute trauma has occurred. Seizure may occur secondary to an acute problem or as a manifestation of epilepsy, genetic causes. The classification of structural metabolic causes include trauma, infection, and metabolic disorder, most common abnormality of sodium, calcium, and glucose, as well as drug or toxins. Isolated seizure with or without recognizable cause with no subsequent sequelae can occur. Focal seizures are presumed to begin in one cerebral hemisphere, in contrast to generalized seizures, which are believed to begin in both hemispheres at the same time. If focal seizure, the degree of impairment in the level of consciousness can be variable. Manifestation may include focal motor signs, automatism, semi-purposeful movement, or autonomic, including somatosensory symptoms. EEG reveal focal epileptiform discharge. Neuroimaging is indicated in all children with focal seizure to rule out anatomic lesion. The term partial simple and partial complex seizure have been abandoned by the ILAE due to imprecise definition of the terms. Based on the American Academy of Neurology in 2001 statement, no lab tests are indicated in children older than 6 months of age with their first non-febrile seizure who has returned to baseline and has no clinical history suggesting an etiology like trauma, dehydration, toxin ingestion, stigmata suggestive of rickets, and other. If the child has not returned to the baseline and there is a history suggesting a problem like vomiting, dehydration, lab pertinent to the evaluation of the suspected problem may be appropriate. A sodium level for children less than 6 months, calcium and blood glucose level are the most likely to be abnormal. A careful history for risk of toxic ingestion should always be obtained and investigated if suspicious. A lumbar puncture is indicated only if age is less than 6 months, if a CNS infection is suspected, or if child of any age has not returned to the baseline mental status. EEG are recommended when a seizure is suspected diagnosis. However, it is not necessary to obtain them urgently. Routine EEG are recommended by the American Academy of Neurology as part of the routine workup of the first non-focal, non-febrile seizure. However, the ideal timing of that procedure is not clear. It should not be done acutely because patient may continue to show a transient post-ictal abnormality for up to 48 hours. The purpose of the EEG is to help predict the risk of recurrence and provide information regarding the child's long-term prognosis. This recommendation may be controversial because it does not influence treatment recommendation. Absence seizures are generalized seizures that typically manifest as brief starting spell, sometime with the automatism. The onset is most commonly between 5 and 8 years of age, although they may be overlooked for prolonged periods due to their very brief duration. Hyperventilation will often produce the event. Diagnosis is by characteristic 3 Hz spike and slow wave complex on the EEG. Myoclonic seizures vary in their prognosis and neurodevelopmental outcome. Infantile spasm are the most serious variant. Symptoms commonly begin between 4 and 7 months of age with the cluster of rapid jackknipping contraction of the neck, trunk, and limbs, followed by a brief sustained tonic contraction. Hips arrhythmia is characteristic finding on EEG. An EEG is necessary to distinguish infantile spasm from benign myoclonus of infancy, a benign involuntary movement, and myoclonic epilepsy, which vary in severity and outcome. Epileptic spasm, which include infantile spasm, are classified as an unknown seizure type because they do not fit well into the generalized or focal subset. Intermittent episode of hemiplegia, which may alternate between sides of the body, characterized alternating hemiplegia of childhood. Onset in the infancy, attacks are more likely to be flaccid in a young infant and more dystonic in older one. Episode can range from minutes to weeks. Other involuntary movement, nystagmus, or autonomic disturbance may accompany the episode. Benign paroxysmal vertigo most commonly occur in toddler. Children experience brief episode of sudden imbalance. They are frightened by the episode and frequently fall to the floor, refusing to stand or walk. Consciousness and speech are preserved. Nystagmus is usually evident. Neurological evaluation, including imaging and EEG, is typically normal, except for abnormal vestibular function noted on ice-water caloric testing. This condition is considered a migraine variant and likely precursor to migraine headache. Paroxysmal head nodding, torticollis, head tilt, and nystagmus characterized spasmus neonatal. Consciousness is preserved. Onset in the first few months of life and it resolved by 5 years. Neuroimaging recommended to rule out tumors. Repetitive, purposeless movement are often exhibited by autistic and handicapped children, especially in environments with a low level of stimulation. They may be difficult to distinguish clinically from seizure activity. Syncopal convulsion may occasionally be self-induced by performing the Valsalva maneuver. Masturbation in young children is also sometimes mistaken as a seizure by parents. Involuntary movement may occur as an isolated entity or as a component of more complex movement disorder. Chorea, dystonia, hypokinesia, myoclonus are examples. Tics and stereotypical movements are described as involuntary movement even though affected individual may have some ability to suppress those motions. Some electroclinical epilepsy syndrome are characterized by both seizure and involuntary movement, but the movement disorder alone can be difficult to distinguish from seizure when they manifest as a perpetual or paroxysmal involuntary movement. In general, movement disorder do not manifest during sleep, have a more stereotypical appearance than seizure, and are not associated with loss of consciousness or abnormal EEG finding. Benign childhood epilepsy with centrotemporal spike, previously called benign Ronaldic epilepsy, typically present as a brief hemifacial seizure. Parents may describe the child face as twisted that awakes the child from sleep. Generalization occur rarely. Drooling and inability to speak are common, but conscious is preserved. The EEG show characteristic centrotemporal spike. Onset is between 3 and 13 years of age and resolution occur in adolescence. The family history is often positive for epilepsy. Narcolepsy is characterized by recurrent short sleep attacks. It's often accompanied by cataplexy, a sudden collapse due to loss of muscle tone, but with preserved consciousness, and induced by laughter, excitement, or startle. Vivid hallucination, visual, auditory, tactile, may occur with the transition to and from sleep. Sleep paralysis may accompany them. Disturbed nighttime sleep is very common. Night terror are a sudden partial arousal from non-REM sleep occurring about 2 hours after sleep onset, accompanied by inconsolable screaming and crying. They occur most often in preschool and early school age children. Children appearing awake but do not recognize people and have no memory of the event. Confusional arousal are similar but less extreme event with a more gradual onset, and the child is less likely to try to get out of bed. Rarely, prolonged episode of hyperventilation may result in loss of consciousness and sometimes seizure activity. Thank you for your listening.